Welcome to Brain Tumor Talk, a podcast brought to you by the Ivy Brain Tumor Center at Barrow Neurological Institute. This show unites leading experts, inspiring survivors, and compassionate caregivers in conversations about the latest in research and treatment. Together, we share stories filled with challenges and hope. I am your host, Michelle Palacino, a member of the Ivy Center team. My deep understanding of brain cancer comes from both my professional insights and personal experience as the daughter of a brain cancer patient. Brain Tumor Talk is your invitation to connect, learn, and find support in this community. The information shared on this podcast is for educational and informational purposes only. Nothing stated on this podcast should be considered medical advice. Welcome to Brain Tumor Talk. I'm your host, Michelle Palacino, and on today's episode, we have two very special guests. Dr. Shwetal Mehta, the Deputy Director of the Ivy Center, and Dr. Charuta Furey, the Chief Neurosurgery Resident at Barrow Neurological Institute. There's been a growing conversation about biomarkers and genetic testing in brain cancer, and today we're doing a deep dive into that conversation. Thank you both for joining us today.
Thank you for having us.
So I want to start this episode off by really summarizing what is a biomarker. I think that's a good place to start in this conversation. So Dr. Mehta, I'll have you kick it off with that.
Sure. So a biomarker is a biological marker that allows us to query if something is changing in response to treatment, in response to the disease. And you could look for those biomarkers in a variety of different locations, in your body fluids, in blood, in your CSF, the cerebral spinal fluid, or the tissue, tumor tissue. Mm-hmm. If those things change, some of the biomarkers people have already done research on, and they found that they change in response to a particular treatment, that's then defined as a biomarker.
So when you say they can test it through like the liquids and through the blood and things like that, is that how the testing is done? So like if a brain tumor patient comes to a hospital, is that really the question that they should be asking, is how is this testing performed? So
pathology is like a broader field where they're going to look for the diagnosis. So they look at is this a tumor or not? Is it cancerous or not? What type of cancer it is? But then when you talk of biomarkers, it's a little more specific. Mm-hmm. So now you're looking, if there are various different types of biomarkers. Some are predictive, so they would predict that there is a disease. Some could be diagnostic, so there've been enough research done that says if you see a change in your tissue or in your blood, it tells you that this is the disease that you have. Mm-hmm. So yes, these kind of testing are important. Mm-hmm. More research has been done where we know a lot more about these and what kind of biomarkers we should be using. Mm-hmm. But it could be done in the pathology lab or in a specialized lab.
Yeah, I was going to ask, how is the biomarker testing different from pathology and genetic testing? Because I feel like there's a lot of confusion around the difference between genetic testing and biomarker testing.
Yeah, and some of those, as I said, it's an umbrella. So pathology mm-hmm. is a wider umbrella that can encompass biomarker testing or genetic testing. Mm-hmm. A biomarker can be a gene, mm-hmm. can be a protein, anything that is different and that tells you like, oh, if I see this, that mm-hmm. means something's going on, mm-hmm. right? Either the disease is progressing or this is a new type of disease that we found. So it just gives you that information. Pathology is much more broader, where a pathologist is going to look under the microscope, look at the tissue and say, oh, I'm seeing abnormal cells. Mm-hmm. They would probably do some sort of staining, and especially now they could look for a biomarker and say, oh, I see these positive biomarker within this tissue. Mm-hmm. A genetic testing requires you now to take that tissue, isolate your DNA from the tissue or the liquid, and then look for a specific mutation that might happen, and that could be a biomarker.
Mm. Go ahead.
Yeah, I think your questions are really interesting, especially for brain tumor patients, because, brain tumors live beyond the blood-brain barrier. Mm-hmm. So a lot of times if you want to access tissue, it requires going to the operating room, which is obviously not something we take lightly. So I think that that's a really important distinction for patients is mm-hmm. A lot of the testing that they'll get in genetic testing, it'll be reliant on getting tumor tissue from the operating room. Now there's an emerging field of biomarkers that are more minimally invasive, using things like spinal fluid, using things like blood, but of course that's all emerging. And so I think that's what's a really interesting thing to think about and talk about, but it's different than maybe some other cancer types where there are some more routine blood tests that you can ask your doctor about. In this field, a lot of times blood tests don't necessarily capture the tumor because it's kind of shielded behind that blood-brain barrier.
So that leads me to my next question about how are all brain tumor patients getting tested for biomarkers? Is that something that, I mean, I know most of the brain tumor patients at the Ivy Center and at Barrow Neurological Institute are, but is that a standard? Because we talk about pathology and a lot of brain tumor patients are receiving specific pathology. It's how they know their treatment plans. How do biomarkers play a role in that?
So there are certain biomarkers that are, at least the World Health Organization and the group of neuro-oncologists have come together and said like we should be doing certain testing. So key ones, which are MGMT, is a commonly done biomarker testing for most patients. Almost every hospital has ability to test for that. Several times some of those decisions are dependent on the physician, on the insurance, and all of those things. But MGMT is one of those biomarkers where there's enough research that has been done to tell you that if you have a MGMT status, which is a particular gene, if it's methylated, which is a modification that happens to this gene. So if you see that predicts that they'll respond better to temozolomide.
Yeah, I have a flurry of questions about MGMT methylation. So a lot of patients know that, if they have a tumor that's MGMT methylated, it's quote unquote better. So do these biomarkers impact prognosis for patients?
They do. The way I like to explain the MGMT methylation, the analogy I like to give is, whenever your body is really good at repairing things, including DNA damage. And so when you have, a drug like Temodar, for example, which is very commonly used, that's going to be causing, it's an alkylating agent, so it's going to be causing damage to your DNA. Now, your body has MGMT-related pathways, and it's this little thing that goes around and fixes that DNA damage. Well, if it's methylated, it's not working as well. So you can imagine that people who are MGMT methylated, they respond better to that drug. And so in that way, these biomarkers are important because they kind of tell you not only prognosis, but prognosis in the context of what kind of therapy you're getting. And so I think that's essential for, patient autonomy and knowing about what treatment lies ahead. So I think it's, most standard treatment questions should be, is my tumor going to be tested for MGMT methylation status? What is the IDH status?
Yeah.
Is it being sent for genetic studies? And then also the standard pathology studies, something we call FISH, which is looking at what do the chromosomes of my tumor look like? So those are kind of standard questions patients ought to ask, and that kind of becomes the tumor's thumbprint.
Yeah, I'm going to ask this question on behalf of most of the patients, I think, because we've heard it quite often. IDH status. So you mentioned IDH status, and can you explain what that is? And then a lot of patients do know like IDH1, IDH1-2, IDH wild. What does that really mean for patients?
Yeah, so IDH is a gene that helps cell metabolize, everything that they take. And, several extensive research was done where they found that tumors that had mutation in this gene for IDH made it aberrant. So it doesn't really do its job the way it's supposed to do. And every time patients who had that mutation seem to have a better response in terms of treatment, those patients lived longer, and then it was later associated with a subgroup of tumors that are slower growing relatively and do better. So I think because now we've done these analyses, there's a lot of work done by the scientists and the clinicians doing clinical trials. It's established that, we should always look for whether IDH 1 or 2, both of them can be mutated. And if they are mutated, that would give us an idea that the patients are going to respond better, and probably, it's a better tumor to treat.
Yeah. Maybe we're getting too into the weeds, but I know I've heard you guys say mutated. And so what's the difference between a mutation and a biomarker, or are they synonymous with each other?
I'd argue that a biomarker is a larger umbrella for things that, are biological markers for a disease process. A mutation is within that umbrella. So a mutation is a specific type of biomarker after you do genetic testing that tells you, on a DNA level, how that protein or how that disease pathway is going to we can predict that it'll act.
So if you think, our cells, our body is made of millions of cells, and every cell has a nucleus that carries your chromosomes. And your chromosomes are built of DNA. And DNA is a string of these, what do you call, nucleotides, and we just assign alphabets to them, A, T, G, C, right? And it's a sequence, and that sequence is extremely important because that sequence tells your cells, this is the gene that needs to be, transcribed, you need to make protein out of this, and this is how the protein should look. Now, if you mess up that sequence, so it's like a message, now I just added, I changed the words around, or, say ARE is R, and now I've just switched that around to RAE, it doesn't mean the same thing, right? So when that happens, sometimes it's okay, it doesn't really mess up the message that much. Sometimes it does. It dramatically changes the protein that is produced from that gene.
Right.
And those are the ones, that's called a mutation. When that switch happens, that's a mutation. And those mutations can then result in abnormal activity. Sometimes it's oncogenes. Now they are just making tons of this protein that should not be produced, and that results in cancer. So I think that's how mutation can be a biomarker. Right. Because especially if you know that when you have this mutation, it leads to this outcome, now you can predict.
Now, I have a question when we're talking about these mutations, and is the biomarker testing subjective based off of different institutions? So a lot of times when we're talking about clinical trials and we're talking about methylation status, there's a lot of discussion around whether maybe a patient's tumor was methylated versus it wasn't. Is there a standard that everyone's following when it comes to this?
Unfortunately, the answer is no. Because there are lots of different ways to query this, different techniques to ask the same question.
Right.
And sometimes the methods are some methods are very sensitive. They could detect even the slightest level of methylation. Versus others are not so sensitive, but those methods have been used, and we've done clinical trials, and we know that if you have a particular threshold, those patients, we can classify them very clearly as methylated, and we know it's going to benefit. The problem always comes when it's in a gray zone, where you're not clearly unmethylated or clearly methylated. And it's that population, until we do more trials with multiple different methods and validate, how can this threshold from this method compare to threshold in this method, right? How can you make them comparable? So more studies need to be done along those lines.
Right.
But there are several clinical trials from which, we know that if you use one particular method and this is the threshold you use, there's clear benefit for those patients.
From a patient's perspective, what's the benefit of having this biomarker testing done? Is it that there's potential new treatment options, or is it just that you have a greater understanding of prognosis?
I think both. I think it answers a lot of questions for our patients. First of all, it kind of tells you, what's the hallmark of my tumor? It's a much more specific way to understand what you're up against. And I think that then that hallmark of your tumor allows you to look at the literature, allows you to see prognosis, natural history of disease, and what has the course been for other people that have the same makeup of their tumor. I think the other thing that's important is it allows you to really determine whether or not treatments are going to be beneficial for you. Every treatment that we give has, side effects to it.
Right.
And so you can have a much more frank and honest conversation when you know, hey, I'm not MGMT methylated. I'm actually unmethylated, so I may not have as good of a response to Temodar, and it has all these side effects. Maybe I want to try a different clinical trial drug. And it also allows you to see which sorts of clinical trials you're eligible for. Most clinical trials have different eligibility criteria that are often based off of these biomarkers. And then finally, I think on a grander scheme, it allows us to better understand treatments for our patients as well. So back in the day, before we knew about IDH1 and 2, we didn't know that there were certain patients that were functionally different. Their tumors were functionally different than other tumors. So we'd give them certain types of surgeries. We'd give them certain types of drugs, and we'd say, hey, these people are doing really well. We must be doing a really good job. It was actually a function of their disease, not the treatment we were giving them. So I think on a grander scale, the more specific we can be with how we categorize, this terrible disease, it allows us to winnow in on better treatments and better understand people's prognosis and how they're responding to treatments.
Yeah. You touched on it briefly with the clinical trials, and I kind of want to dive into that realm. A lot of the patients who are looking at clinical trials are patients that have had a recurrence, and that's really kind of what brought them to like that second avenue of care. So when we're looking at genetic testing or mutations or biomarkers, if a patient has a recurrence, is it the same biomarker? Is it the same tumor, or does it need to be retested?
It's a great question. I think, it can be similar in many of its biomarkers and a lot of its genetic makeup, but we know that generally during recurrences, a lot of the time there's something that's functionally changed. Now, gliomas in particular are difficult because they're very heterogeneous. So genetic makeup even within the tumor is different. The microenvironment within the tumor is different. So anytime someone does recur, it is very important to get that tissue, to send it again for tumor tissue testing. And it's not uncommon that we see, say, a different type of amplification or a different type of mutation or different types of genetic changes, not just on the DNA level, but even on the RNA level. From the work that we're doing here at the Ivy, we see that quite commonly. So I think it's important to make sure that you get that testing, and then that way you can see if you can enroll into different types of clinical trials. A lot of times, even when you know that you have a recurrence, and you know you need to go to surgery, that's a good time to also look for clinical trials, because whichever institution you're enrolling in can then, you can go to the operating room with that institution, and they can take that tissue and do that testing to see how you'd respond on that particular trial, which is what we often do at the Ivy.
What do patients who have an inoperable tumor do when it comes to if it requires tissue sampling?
There's a lot of options on the neurosurgical side. There's we never take the decision to go back to the operating room lightly, and we have a very frank conversation about where your tumor is, what kind of side effects you can anticipate, particularly given whether it's in a high real estate or low real estate value of the brain, and if it is deemed high risk for an operation, we can still do what's called a needle biopsy, which is minimally invasive, and it allows us to get a small amount of tissue without subjecting someone to a large operation.
So are all clinical trials based off of biomarkers?
Most of them are, because you want to make enroll patients who have the highest chance of being responsive to the treatment. But it depends on the drug. So every drug, it'll be a different set of biomarkers, different level of intensity of how many biomarkers you have to query. Some may be just one. Others, you might have to look at a battery of 4 or 5 biomarkers.
I think that for most patients, the diagnosis of even a brain tumor is shocking. And then you even get down to the details of glioblastoma. And this is probably the first time a lot of people are hearing that term. So when you're talking about, your average person, they're really not going to have a lot of knowledge about like the biomarkers and IDH and MGMT. A lot of this is all new information. So how would you recommend patients go about finding clinical trials based off of biomarkers? It's a rabbit hole of complexity. And so I think that that's something that's probably overwhelming for the average patient. So what would you say to your patients that are, trying to explore these other treatment avenues?
Yeah, I think the first thing is, I really think it's important to rely on your providers. As a chief resident, I'm often the first person that tells someone that they have a new diagnosis of a brain tumor. And that's exceptionally difficult, but also spiritually fulfilling in some ways to be there and answer questions. And so first thing I'd say is, don't feel like you can't ask questions. Don't feel like you can't rely on your providers. That's why we went into this field. And so I'm always thrilled to answer those questions, walk through the imaging, walk through the genetic testing. And you'll also have a neuro-oncologist, often a radiation oncologist. All of these people are part of your team, but at the end of the day, you're the quarterback of that team.
Right.
And so there are also a lot of fantastic organizations and resources online, particularly if you're in an area where maybe there's not as much access to certain types of healthcare providers or subspecialists. So the American Brain Tumor Association does a fantastic job. Their website and webinars, they have a lot of great education on each of these different types of biomarkers. And they even highlight and look at emerging therapies and emerging technologies as well. And they're fantastic. They fund a lot of these researchers as well. So that's a great start. They have a fantastic website. I think most institutions that are nearby, so the Ivy Center, for example, has a great website that details all the different types of clinical trials that we have. Under the inclusion criteria area is typically where you can see what types of mutations qualify you for a particular trial or what sorts of biomarkers. And then, of course, you can always go to clinicaltrials.gov to look there. There is more of a laundry list of trials to choose from.
And I know we've talked about a few of these. I mean, that's really helpful. I do think that the American Brain Tumor Association is such an amazing resource, and for patients and caregivers. But, hearing it from the horse's mouth, what advice would you give to patients who maybe are trying to ask their physicians? What questions would you recommend that patients ask their physicians?
That's a great question. I think the first question to ask is, I'd really like to know more about my tumor and what I'm up against. And asking, what is the genetic profile of my tumor? What other sorts of testing has been done on my tumor? And getting a very specific answer and making sure you have records of all of that so that you can look at different types of clinical trials and be in the driver's seat of your treatment. I think after that, what sorts of treatment options are available to me? What do each of these look like? And when people do give you the treatment options, really understanding the pros, the cons. So what benefit can I anticipate? And saying I'd really specifically like to know what benefit I can anticipate based on clinical trials. How many more months does this give me? What are the adverse effects? And then finally, I think it's important to see, have an evolving conversation for all of these things too. So certain types of treatment like Optune, you have to wear around the clock. They have a large, sometimes burden on quality of life. And so continuing to have that evolving conversation with your provider to say, hey, this is how this is going. This is what the con or impact actually is on my life. What kind of benefit can I anticipate really in specific terms?
Right. You made me think of quality of life and surgery and a lot of these like invasive treatments and things like that. The Ivy Center has launched a liquid biopsy program in 2022. Right? It was in 2022 we launched it to obtain real-time insight into genetic profiling. And Dr. Furey, I know that you've kind of led that charge. Can you kind of talk a little bit about that program and what it means for patients?
Absolutely. So, I think that one of the large barriers that we have in clinical trials in general is having access to tissue. So a lot of the time, a patient comes in, they get surgery, we have tissue from that time point, and then they enroll in a clinical trial, and very few of them go back to the operating room. So it's difficult for us to know, what's happening in real time to their tumor, if the pathology is changing at all, is it responding to our therapies? Why do certain people respond whereas others don't? And then many times, the way that we monitor them is with radiologic scans. Patients are probably used to getting an MRI and some amount of frequency. So when the MRI doesn't change, what's actually happening with my tumor? What's happening with my disease? The MRI is clear, but we know that tumors still come back down the road. So what was happening during that period of time? And then when there are changes on the MRI and they're kind of equivocal. Right. So is this actually my tumor coming back, or is this my body reacting to radiation changes? Do I need to go back to surgery in order to figure that out, or can I stay the course because I feel pretty great? So those are all really big treatment questions that we ask all the time during tumor board. And so that's what inspired this program, was to be able to find a minimally invasive way to track disease, and especially track disease when patients are on clinical trial. One of my favorite Wayne Gretzky quotes is, skating to where the puck is going. And so this is a way to maybe see which way the puck's going and get ahead of it. So we have patients who have an intracavitary ommaya. So after they get surgery, we place a small little bubble or port that has a tube that goes to the cavity of the tumor. And then as an outpatient, we can effectively query that area where they had tumor tissue to get spinal fluid and look at biomarkers within that spinal fluid. So we look at DNA as well as RNA. So different types of genetic information, one of which tells us the actual genetic makeup of whatever is floating around in that fluid. And then the other is, another way of looking at that. So as you remember, you have DNA that goes to RNA that goes to protein. So you can actually see not only what is the genetic makeup within that fluid, but also what's actually being produced, what's actually being transcribed. And so that's a really interesting and important way to monitor disease. Obviously, this is an exciting new way of research.
Right.
And spinal fluid has had a much better yield for being able to query these questions. But there are other groups that are also looking at blood, but it's a lot harder to pick up on some of that tumor tissue, but that's even more minimally invasive and hopefully the future.
Yeah. So this ommaya reservoir, it sits in the cavity, and is it a routine procedure that we're doing pretty often, or is it an invasive procedure? How are you getting the spinal fluid from the reservoir?
Yeah, so placing the actual ommaya reservoir is quite routine. We just leave it after surgery, so it's not an additional surgical procedure or anything like that. And then when they come to clinic, it's just a tiny needle that goes under the skin in order to draw that fluid. So there are some other places where they've looked at even doing lumbar punctures to get the spinal fluid, which is also a lot more minimally invasive than going back to the operating room for craniotomy.
Right.
We've found that this is even more minimally invasive because it's just right under the skin. It's a 5-minute procedure. It's very quick. That said, of course, anytime you put in an ommaya reservoir or any kind of hardware, it comes with an increased risk of infection or revisions. We haven't had that issue. It's been quite safe. But that's always something that you have to discuss and think about.
Yeah. I mean, I do think that it's an amazing resource for patients that are here and that have access to a facility like this and resources like this. For patients that are listening that maybe don't have the access to this, I think that there's a lot of buzz around the term next generation sequencing. And I'm not sure if I'm on the right path or I've just totally jumped trails, but I'm hoping, Dr. Mehta, that you can talk about next generation sequencing and maybe what it means for patients and how advanced is it and what.
Yeah, so there are various forms of sequencing methods. So sequencing basically means that you are going to read that genetic code that I was talking about. And what you do in this next generation sequencing is you look across the entire genome to see what's normal, what is mutated, and get some information. Now that sequencing can happen for the DNA, but you can also do sequencing for RNA that Dr. Furey was mentioning earlier. Both of them give you information of mutation and what messages the cell is sending out, right? And how is that changing in response to treatment, in response to the progression of the disease. Next generation part of it is just everything. The technology has become so much faster, cheaper, literally, so that earlier we could only sequence a single gene, and it takes us weeks and weeks. And now we can sequence the entire genome within few days. So that's the difference, and how fast, how quickly we can query, how much information we can get about each of these tumors.
Can you talk a little bit about like the technology behind these sequencing? Is all of these institutions using the same technology, or is it based off of kind of the high volume center, or is it, I think we have a unique sequencing, but I'm going to leave it up to you to really dive into that because...
So as I said, you can, query the entire genome, or you could just look at targeted genes that are most important.
Right.
And that's the most cost-effective way and beneficial way of doing the analysis, which is what most centers do. What most centers do is identify the top most commonly mutated genes that can help either predict or what kind of drug might work best in that situation, or give us more information about the tumor itself. And that panel can change. And so we at the Ivy Center also have a panel, we call it the Ivy Seek. It's a set of genes that we query that will help us identify which patients have those mutations and how will that qualify them for our ongoing trials.
So you mentioned in that the most commonly mutated genes for brain tumor patients. What are those?
So some of the common ones that you'll hear a lot are EGFR. We have lots of inhibitors that target that pathway whenever you have mutations. You'll hear about gene fusions. So there's something called FGFR that's fused, where two genes are fused, and now that causes aberrant behavior, cells to grow. And there are drugs that can target that. You'll hear CDK4/6. These are proteins that are really important for cells to divide, and there are inhibitors for that. So these are some commonly mutated genes in GBM.
And these are kind of would you say that patients should maybe reach out to their doctors about these specific genes, or would you say maybe not so much, you're getting way too in the weeds?
I think way too in the weeds. Common thing, there are several agencies that do these tumor profiling, molecular analysis, where you would then get a report and you would have information of what's mutated, what's not.
Right. Well, thank you guys. I know I'm going to, again, pivot really quick. So when this episode airs, the two of you will be in Houston attending the Society for Neuro-Oncology, the SNO conference. And so I kind of want to ask you, like I mentioned at the beginning, there is a lot of discussion around this topic. And so I was just hoping for patients and families who are unfamiliar, can you tell us a little bit about this conference and some of the research that's presented there?
So this is a great platform. It's an international meeting that happens every year around November, where physicians, scientists, clinicians, nurse practitioners, all of them come together to discuss the latest advancements in our field. This is an opportunity to present your findings to the community, and for the community to ask you questions, if they have doubts, was this well thought out? Did you answer all the right questions? It's also a place where we can have collaborations, because something you've not thought about, but somebody else has an idea that you can work and collaborate with. And a lot of exciting science will be presented at this meeting.
So how does this impact the research that's being done across other facilities? And not only ours, because I know that we really take the information to heart. We pay attention to the studies that are really promising. But how would you say that this impacts research in the field?
I think it's a fantastic resource for researchers, in particular, given its interdisciplinary nature. So you've got, basic science PhDs, as well as clinicians, patients and their families. And what's really wonderful is just the synergistic effect of the meeting. So not only do people present, these massive trials that have, and with their experiences, they even present negative results. So it allows other institutions to see, what didn't work, which is equally important, even if that doesn't necessarily always make the news.
Right.
So that's important for the field. And then in particular, it allows us to not be quite so siloed. So you'll present something and someone else will come up and say, hey, I've actually got a mouse model that, has this amplification. And I think it'd be really helpful for your studies to functionally validate what you found in patients. And so I think that allows us to move at warp speed as a field. And the organizers of these meetings do a fantastic job. It's usually a multi-institutional panel of people that bring these meetings together. And so it allows us to have a lot of diversity of thought. And geographic diversity as well. It's an international meeting. So you'll see, what they're doing in Heidelberg. You'll see what they're doing across the pond and learn from their experiences. In particular, given there's even different health systems over there. So they have a different way and ability to leverage clinical trials. They have larger registries for their patients. And so allows us to all benefit from each other's clinical experiences.
Well, I know you guys are both going, so I hope that you guys have a good luck when you guys are presenting all of the abstracts and poster presentations and things like that. To wrap up the episode, I want to ask you both one question. Well, we'll do a quick fire at the end, but just related to biomarker testing and genetic profiling, what do you find to be the most promising or exciting thing on the horizon?
I'm thrilled by the idea of liquid biopsy. I think that it's important for us to be able to really specifically track disease, to offer information using minimally invasive approaches. And I think it'll allow us to better understand things in the context of experimental therapies. Is this therapy actually working for our patients? And I think that's been a large barrier for clinical trials. A lot of times we put people on treatment and we don't know if it's working. We don't know why certain people are responding. And it hinders us significantly in the brain tumor space relative to other types of cancers where you can much more easily access tissue. So I think that's a very exciting new area of research that'll be really great for our patients.
Thank you.
I would say along the same lines, very excited about the fact that we know so much more about this disease than before. And we're able to now do these type of trials where we can query whether the drug is working for the patient or not, and move those drugs forward. So I think I'm looking forward to more centers employing some of those methodologies and really finding good drugs for our patients. I think we are at the right time right now.
Well, thank you both. I'm going to say, and it's going to, at the risk of sounding a little bit cheesy, I'll say it, but I think that a lot of times this prognosis can sound a little bit hopeless. And I think that both of you are doing such incredible work. When it comes to this advanced research that's happening, you guys are making a difference for patients and caregivers. You're giving hope. You guys are progressing the field forward. And there's something to be said about the work that you guys are doing. It's really incredible, and you're on the front lines of saving patients, and that's something special. So thank you.
It's a privilege.
So to wrap up the episode, yay! To wrap up the episode, we often hear the term one day at a time. So on each of these episodes, I'm going to ask you kind of a quick fire, and you just kind of give your one piece of advice or one thing that's meaningful to you. Here we go. Okay, so what's one piece of advice you'd give to your younger self?
Enjoy life, spend time outside, do things that, you really enjoy.
What's one thing people would be surprised to learn about you?
I'm like a prankster. I like to prank people.
What's one thing you do to de-stress?
I love going on hikes, nature walks. That's my thing.
What's one habit you'd like to break?
Check my phone as soon as I get up.
What's one book you'd recommend everyone reads?
I've been reading this book from Adam Grant called Hidden Potential. I really highly recommend people.
What's one thing you're most proud of?
I think if I look back on my life and how far I've come, I would say I'm very proud of me being persistent and being here.
If you weren't the deputy director of the Ivy Center and the incredible researcher that you are, what's one profession you'd want to try?
Oh my God. I think I could have become an interior designer. That was one thing I wanted to do. Go into forensics. That was my other thing, which my family, vehemently said no.
What's one thing you'd like to be remembered for?
Making an impact, making people feel like, they've contributed, also helping mentor students and trainees.
Okay, thank you. And if it means anything, you definitely have left that impact.
Oh, thank you.
Even if it's just with me.
And me.
Aww.
Okay, you ready?
Yes.
So what's one piece of advice you'd give to your younger self?
I'd just recommend practicing gratitude, being grateful for everything that you have.
What's one thing people would be surprised to learn about you?
I was a college cheerleader, and I've continued to be a cheerleader for my patients and the people in my life.
What's one thing you do to de-stress?
Spend time with my family and my lovely 3-year-old.
What's one habit you'd like to break?
Skipping breakfast.
What's one book you'd recommend everyone reads?
Oh gosh, I would be remiss if I said I don't have much time to read for pleasure anymore. One of the last books I read was Making of the Atomic Bomb by Richard Rhodes, and I think it's a really beautiful story that underscores the importance of, scientific knowledge being exchanged and how that really impacted one of the most important technological creations.
If you weren't a neurosurgeon, what's one profession you'd want to try?
I probably would have still done some kind of surgery. I considered doing reconstructive pediatric plastic surgery, craniosynostosis remodeling and things like that, as well as being a neuro-oncologist or a radiation oncologist. I really enjoy taking care of tumor patients.
It's in your blood.
Yeah, I can't imagine anything else.
What's one thing you're most proud of?
My family and my patients.
And then what's one thing you'd like to be remembered for?
Making a difference in the lives of people around me and the lives of my patients.
Well, thank you both so much for joining us. I know that this episode was extremely informative, so I appreciate it.
Thank you.
Thank you. We hope this episode has informed and inspired you. Subscribe to Brain Tumor Talk so you don't miss another episode, and please consider leaving us a review to help others in the brain tumor community find us.